Good afternoon, everyone. iTech India welcomes all the participants for today's special NDLS session. Today, we'll be covering cervical cancer among women living with HIV, screening, linkages, and treatment. We have with us today Dr. L. Swasticharan Sir, Additional DDG, NCD, and Director EMR, DGHS. Dr. Chinmoyee Das Ma'am, Head CST Division, NACO. Dr. Rajesh Kumari Ma'am, Additional Professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi. We welcome you all for today's session. I now request Dr. Swasticharan Sir for opening remarks.
Good afternoon, friends. Can somebody confirm whether you can hear me?
We can.
Yeah, I see Dr. Chinmoyee noting. Thank you so much for inviting me here. And I'm honored to give the opening address for this very important critical issue of cervical cancer screening among women living with HIV. We run a national program for the NCDs, which is known as the National Program for the NCDs, and we do, 3 common cancer screening already: oral, cervical, and breast. And I would like to particularly thank Dr. Chinmoyee for this important webinar, because while we are, garnering the nation for screening so that we can diagnose people early for these 3 common cancers, we have to identify some of the vulnerable groups. So because of inherent issues, inherent stigma associated, inherent inertia associated in the health-seeking behavior, etc., there could be so many areas where we need to pitch in to increase the level of screening in terms of among the women living with HIV. So today, during this webinar, we are trying to raise awareness, also increase the visibility of the program component of cancer screening. We are here to share knowledge. We are here to discuss strategies to enhance cervical cancer screening efforts within this vulnerable population. Friends, cervical cancer remains a very significant public health challenge globally, and particularly in India. This is the second most common cancer among women. The WHO has also launched a global strategy on 17th November 2020 to accelerate the elimination of cervical cancer as a public health problem. Women living with HIV are at a substantially higher risk of developing cervical cancer due to various reasons, one of them being immunosuppression and also the persistent infection with high-risk human papillomavirus, what is commonly known as HPV. So there are many strategies. Some of those key strategies could be we try as a country to contribute, contribute to our efforts, as we are the second highest number of cervical cancer cases globally. We need to identify this and we need to address this. And also cervical cancer being the 4th most common cancer in women worldwide. So we need to, highlight this so that we get enough focus, enough, kind of visibility for this component. And women with HIV are 6 times more likely to develop cervical cancer compared to those without HIV. So these are some of those key statistics why we need to increase our attention here. We think that we have rolled out a program for the national program for NCDs, which does not discriminate anybody with whether they are having HIV or not, and they are supposed to, access the services available there. They are supposed to get screened for the 3 common cancer. That's what we program officers sitting in the center thinks that. But in the fields, it has a different picture. People do not come out readily. Even normal, healthy non-HIV patients do not come out for this particular cervical cancer. Then if we have a vulnerable group because of various inherent factors, they are not coming out, then we need to increase our efforts. We just cannot be a passive program officers, sitting that we have put the services. It is up to you to utilize the services. So that's why we are teaming up with national health control organizations so that we achieve certain objectives. So the objectives which we are trying to do through this webinar is we are trying to increase or enhance the screening by implementing effective cervical cancer screening methods for these people, these women living with HIV/AIDS, and utilizing, say, for example, visual inspection with acetic acid, what is known as the VIA method, as a cost-effective approach. And also, we are trying to, after the screening, we are trying to also and increase the linkages to care. If you screen somebody, if you find somebody suspected to be having cervical cancer, we need to confirm the diagnosis and also the referral mechanism in such a way that the ART centers, where they usually frequent for their other needs, and the cervical cancer screening facilities at the district hospital or the NCD clinic at the community health center, all these are linked together so that we ensure timely diagnosis and treatment. Wherever required, we have to link them with the tertiary cancer care centers as well. And we would also like to raise awareness through this webinar about the cervical cancer risk among the general population, particularly among the women living with HIV/AIDS through preventive measures. We would like to also prevent some of them, and also increase the visibility about the available services, with this population, and also the healthcare providers in both sides. It could be, the NCD program officers, NCD program, service providers like the NCD clinics. When they are providing the services to this population, they need to be even more sensitive than the general population, because with great difficulty, they have come out of the comfort zone of the ARTs, and they have come to the NCD facility for availing the services. That, to me, as a program officer, is an achievement if they do that, and we are trying to do that. And when that happens, we should ensure that the best services are available at the minimum waiting period of time, and the best quality services are available there, and also a robust referral mechanism is existing through that system. So through these efforts, of collaboration between the NPNCD and the National AIDS Control Organization, we are trying to achieve certain outcomes, like increasing rates of cervical cancer screening among women living with HIV, and also improve the linkages between HIV care services and cervical cancer treatment facilities. So, for example, once we forest into this area, we might start thinking that for people living with HIV/AIDS, the services can the screening continue to happen in the NCD clinics or the district hospital, or can there be some kind of a focused screening in the ART centers? Can we do some collaborative activities with the NCD team, etc., that for a better result for increasing the cancer screening services? That kind of operational learning is also expected from this webinar. We have designed something with a lot of input from all the program officers from both the sides, but those people who are implementing it, they are the best people with the best wisdom. So you will have to tell us whether this will work or not, and if it is going to work, how it is going to work also. And also the third most important outcome which we are expecting from this is, once we have improved the linkages, once we have improved the screening, we should be able to reduce the cervical cancer morbidity and mortality rates among these women through timely diagnosis and treatment. So we'll be able to save people, we will be able to reduce people suffering from the disease, and we'll also be preventing premature mortality, which would have happened if we have not done this kind of concerted efforts between National Program for NCD and National AIDS Control Program. So these are the broad objectives, and we'll be happy to hear to the experts speaking on the integrated services, enhancing awareness, and also promoting preventive measures, which we are hopeful that we'll be able to reduce the morbidity and the mortality. I look forward to engaging discussions during the webinar, and I hope that our teams here, both at NACO and NPNCD program, who are sitting with me, would be able to provide would be able to provide the insights into both the programs, and also more importantly, learn from the field, from each one of you who have joined this webinar, that we all agree that we are going in the right directions. If not, we will also try to do what is known as mid-course correction and improve or change our strategies for a common goal for both the programs. So with this, I thank Dr. Chinmoyee and the entire team there for inviting us to join this important webinar along with NACO. Thank you very much, Chin.
Thank you so much, sir, for your kind remarks and guidance. I now request Dr. Chinmoyee ma'am for the remarks.
Yeah, thank you, Shweta. Thank you, Dr. Swasti, for really giving the opening remarks, which is very apt in today's context. As Dr. Swasti rightly mentioned, that women who are HIV positive are 6 times more prone for cervical cancer because 1, immunosuppression, 2, maybe the other risk factors related to HPV if they have a high risk, they are in the high risk group. So therefore, let's not underestimate or undermine the reason why we are doing this activity. Like any other woman, they are prone for NCDs, but women who are HIV positive are 6 times more prone for cervical cancer. That's what the global evidence says. Now, the reason we wanted to do this webinar is 2 things. 1, we need to create more awareness. 2, we need to promote screening, early screening, so that we diagnose this woman early. That is the main purpose, because we have to understand, if we are diagnosing them early, then there is a chance of getting them cured and treated, and they'll have a good quality of life. So with the ultimate aim of giving them a good quality of life, we have to ensure that they are screened early. Now for screening, the demand has to be generated from the woman themselves coming and saying, yes, I want to be screened for cancer cervix. And on the other side, from the health system, we have to ensure that our people sitting in ART centers or those in NCD clinics, they know that they have to screen, their capacity has to be built, and the different paraphernalia, consumables, testing kits, and everything has to be made available. So this operational availability of logistics and building capacity of our ART center staff or NCD clinics or the gynae OPD where they are going to be referred. So that is again the mandate of both NSCP as well as NCD program. So for taking this activity forward, for understanding the operational challenges, we have initiated this activity in 11 states, 22 districts to be precise. And we want to understand what are the challenges, 1 in logistics, 2 in patient flow, 3 in data management. Because for every health program, data management is equally important as patient management. So this integrated service delivery for HIV and NCD we have started. And here, cancer cervix referral will have a very different path, because this will be referred mostly to the gynae OPD. So therefore, you all are ART center staff who have joined here. I will request you, make sure that you have mapped the right gynae OPD consultant or doctor, where you will refer your HIV positive woman, and she will not be facing stigma and discrimination when she goes for screening. So that is your responsibility to make sure that you have sensitized the gynae OPD, consultant or staff nurse or whoever is going to screen, that this HIV positive woman who is coming for cancer cervix screening is not stigmatized or discriminated. So that is one thing I will request all our ART staff to make sure is in place. And next, going forward, when we learn something from the pilot that we are doing in the 11 states, when we do a nationwide rollout, perhaps by then we will also understand the data management part, the integration of our IT portal, SOCH portal with the NCD portal, and how to link with the tertiary cancer care centers if somebody who is positive who is not being managed at the district hospital is being referred to a higher tertiary care hospital. How do we manage the data and also the patient follow-up? So we hope that Dr. Rajesh Kumari is going to take us through most of the technicalities related to cancer cervix screening. We hope that you all learn a lot and please ask questions. So we'll also have Dr. Purnima from NACO who is going to answer your queries related to the program. So thank you.
Thank you so much, ma'am, for your guidance. We now request Dr. Rajesh Kumari, ma'am, to please start the session.
Good afternoon, good afternoon, ma'am. As sir and ma'am has said, awareness and timely concern in the clinic is most important part of women living with HIV disease to cure or to diagnose regarding cervical cancer. So we will discuss about epidemiology. Nowadays, global and national burden of cervical cancer has been, I think, has been increased because we have a reach at the periphery level also, and we have make available small tools for diagnosis of cervical cancer or precancerous stages. So we will, according to guidelines, what are the high-risk factors contributing to the increased incidence of cervical cancer in women living with HIV, and the importance of screening and early detection for these women, and diagnosis and staging of cervical cancer by different treatment modality, and regarding prevention, cervical cancer prevention strategies, and what are the palliative care in women with the HIV with cervical cancers, and role of ART center and NCT fit facilities. So according to Globocon 2020, the WHO officially launched the strategy to accelerate the elimination of cervical cancer. And targets of global strategy are by 2030 to 1970-90 to vaccinate 90% of eligible girls against HPV, because HPV virus is most commonly 16 and 18 is responsible for cervical cancer. To screen 70% of eligible women at least twice in their lifetime, and to effectively treat 90% of those with a positive screening test or a cervical lesion, including palliative care when needed for these women. So, in globally, Asia contributes to the maximum cervical cancer cases, and among the Asian countries, India contributes to the second highest number of cancer cervix cases. And globally, cervical cancer is fourth most common cancer in female, and in India, it is second most common cancer in Indian female. So globally, cervical cancer is the fourth most common cancer in women, and approximately 1 in 20 cervical cancer is attributable to HIV. And in 2022, an estimated 660,000 women were diagnosed with cervical cancer worldwide, and about 350,000 women died from the disease. In India, as per HPV and related cancer fact sheet 2023, incidence of cervical cancer is 1,23,907, and mortality regarding to this is approximately 77,000, and prevalence of cervical cancer is 3.4 lakh in 2023. So women with the HIV are, as ma'am said already, are 6 times more likely to develop cervical cancer because of immunosuppression. And they are more prone to acquire HPV virus infection, which are less likely to clear due to compromised immune systems and leading to persistent HPV infection. The progress of progression of HPV infection to cervical cancer is expedited in women living with HIV and taking approximately 5 to 10 years as opposed to the typical 15 to 20 years in negative women. And HIV infection is also associated with more extensive cervical lesions, which are 3 to 5 times more prevalent in women with HIV than in those without HIV. And India ranks third globally in terms of HIV burden, and the added burden of HIV attributable cervix cancer compounds the existing challenges associated with cervical cancer prevention protocol. So, as a comprehensive care package, I think awareness is most important. If they are aware about their health conditions and what are the risk factor in women living with HIV, then they can reach for screening, cervical cancer screening, and its risk factor, and appropriate referral for diagnosis and management shall be included to all women living with HIV. Risk factors are in cervical cancer cases, 99% are linked to infection with high risk human papillomavirus and extremely common virus transmitted through sexual contact. Other risk factors during progression of disease are grade of oncogenicity of the HIV type, as most common is 16 to 18. And at our center, there are many projects are now going on regarding self-sampling for HPV virus and women who are HPV virus positive, high risk for the HPV 16, 18, and if during pap smear, if there is any positive finding, then we are going to do their colposcopy and colposcopy guided biopsies also. So grade of oncogenicity of the HIV type, their immunostatus, and presence of other STDs, number of birth, and young age at their first pregnancy, because they are in reproductive age group. Other hormonal contraceptive use and smoking. So referral for cervical cancer screening of women living with HIV at ART center. This is important when any woman reaching at the center. So there should be a care coordinator, as we have our MSSO, medical social worker, who will fill patient's visit register, hands over with white card, and staff nurse will document the process of referral to nearly center undertaking cervical cancer screening and follow-up for forms for investigation. Keep check on women living at the HIV screen positive and coordinate with CSCs for accompanied referral for treatment of precancerous or lesion or cervical cancer till treatment completion. And apply the screening stamp on the green book of patient's referral for screening or fill referral slips. Counselor should give information on the risk of cervical cancer and benefit of early diagnosis through screening part. That is by many methods, so they can aware about their condition, provide psychological support for women, those who are screen positive, and reinforce to the treatment adherence. So then Dr. will do update regarding this on Soch regarding screening and screening outcomes, and generate due list and list of those screen positive, share with staff of linked CSCs. Pharmacist reinforce treatment and adherence to treatment and documentation in Soch, and if patient leave for home, white card given to data manager. So ensure appropriate references, referral, and documentation of referral slip. That is baseline investigation or entry in the Soch. And medical officer will refer these women ever sexually active for cervical cancer screening or as per national guideline. Responsible for the completion of Section 12 and Section 13 of the patient white card or in green book, and assess for any symptoms and sign of side effect of the treatment and refer to the palliative care as and when required. How to approach for a screening and treatment in these women. So in a screen and treat approach, treatment is provided based on a positive primary screening test alone without any triage, no second screening test, and no histopathological diagnosis. So that is screen and treat approach. When the patient is eligible for any ablative method, this should be ideally be done immediately at the same visit as the screening test. For that, we have to have all the things along with us in the either in the OPD or in gynae OPD. They can send patient directly to the gynae OPD with the referral slip, or they can approach to the ART center. At some facilities, this is not feasible and a second visit is needed. So women who are not eligible for ablation can have excisional treatment on the same day if the clinic has capacity of LEAP. If LEAP is not available, women need to be referred for excisional treatment or for further evaluation. So in screen, triage and treat approach, the triage test is done if the primary screening test is positive. And the decision to treat is made when both the primary test and triage test were positive. A positive triage test can lead to colposcopy with biopsy and histopathological examination for diagnosis to determine the appropriate treatment. And when the primary screening test is positive and the triage test is negative, women need appropriate follow-up evaluation at a specified date according to the recommendation. So, when to screen, where to screen? All women and girls living with HIV who were ever sexually active, were at the ART center or PSC, CSC and medical college center. And when to screen? ART native screening at the time of ART initiation, and if negative, repeat screening every 3 years up to 65 years of age. On ART, screen as soon as possible, and if negative, repeat screening after every 3 years up to 60 years of age, anytime if related. Who will screen? Gynae in the gynae OPD or NCD or tertiary care facility or at campsite. How to screen? Primary screening is by visual inspection with acetic acid applied and under NP-NCD and pap smear at the medical college or tertiary care facility, and triage whenever there is colposcopy is available with or without biopsy. As per NP-NCD, screen, triage, and treat approach is followed for cervical cancer, and methods are visual inspection of acetic acid, pap smear at medical college or tertiary care facilities, and method for triage test currently available under the NP-NCD colposcope or with or without biopsy. In the current population based screening program, VIA is adopted for cervical cancer screening because of the high cost of setting up cytology for pap smear and HPV testing. Because VIA, we can directly see the changes on the cervix and we can send them to tertiary healthcare facility or medical colleges. And HPV testing nowadays, there are many projects are going on for self-sampling, or they can approach to the center where is HPV testing is available. But HPV is still not cost effective. There are many challenges. So visual inspection after applying acetic acid, 3 to 5% of freshly prepared acetic acid is generously applied on the mouth of cervix and look for the area and presence of any estovite lesion. Result of VIA, normal squamous epithelium will appear as a pink and columnar epithelium as uterus appear red. In condition like where is inflammation, benign or malignant growth, the epithelium contain lots of cellular proteins because of increased nuclear activity, thereby give a dramatic dense white patch that is called VIA positive. Algorithm for the screening and diagnosis of cervical cancer among women living with HIV. Women living with HIV ever sexually active, referred for the primary screening at ART center or as soon as possible for those on ART. If she is screened positive, then refer for the triage testing. If triage test is positive, then diagnose precancerous lesion and diagnose as cervical cancer. They will refer to the cancer treatment center for appropriate treatment. And 1 year post-treatment follow-up at the treatment center. If woman screen negative, then referred for follow-up screening after 3 years, and triage test is negative, then refer for annual follow-up primary screening for 3 years. If all 3 annual follow-up primary screen are negative, then refer for screening every 3 years. Follow-up screening, if primary screening is negative, then we can go for repeat screening to be done every 3 years. Primary screening is positive, but the triage is negative, then follow up with VIA PAP to be done every year for the 3 year. If the 3 annual VIA PAP smear are all negative, then we can repeat screening to be done every 3 year. When primary screening is positive and triage test is also positive, then these women should be referred to the nearest NCT treatment facility or for further treatment and management based on the convenience of the patient and facility where appropriate treatment service are available.
Ma'am,
Yes.
excuse me, ma'am, can you please indicate next when you're going to the next slide?
Okay, sorry.
Thank
I'll
you.
do. So next slide. So, operational framework for cervical cancer diagnosis under NACP, where, what, how, who, and when. So, where at all diagnosis of cervical cancer, when primary screening is positive at the gynecology, OPD, NCD facility, or campsite. What if women with living with HIV positive on primary screening for triage test, then how these patients are referred to link secondary or tertiary care facility through ABA ID created on NCD portal or through referral slips. Gynecologist or medical officer, staff nurse, and trade ANM can do primary screening test. And when the primary screening result is positive for the woman living with HIV, we have to further refer to them to the secondary or tertiary care facility. And their triage test and confirmation of the diagnosis can be done. And if colposcope is available, then we can go for colposcopic guided biopsy and refer to the further higher center and schedule as per patient convenience. Next slide, please. So, precancerous lesions are, as reference study have found that most intraepithelial lesions are caused by the presence of HPV virus, and other associated factor are immunosuppression in these women, multiparity, and other viral infection also. So, cervical squamous intraepithelial neoplasia refer to all squamous alteration that occur in or near the transformation zone in association with HPV infection, thereby encompassing the treat condyloma, CIN dysplasia, or squamous intraepithelial lesions. What are the invasive cervical cancer? That is a definite diagnosis of invasive cervical cancer is made by histopathological examination of a biopsy, and there are stage 1, 2, 3, 4. Stage 1, invasive carcinoma, that is strictly confined to the cervix. Stage 2, locoregional spread of the cancer beyond the uterus but not to the pelvic side wall or the lower third of vagina. 3, the cancer has spread to the lower part of the vagina or the wall of the pelvis. 4, the cancer has grown into the bladder or rectum or to far away organs like the lungs and bones. Next slide, please. So, operational framework for cervical cancer management. For after they are diagnosed with cervical cancer, so where to go at the tertiary care facility and treatment of precancerous lesion or invasive cancer, and regular follow-up visits should be done. In women who are pregnant, good practice include deferral of the treatment until after pregnancy if she is not in advanced stage. As per NPA-NCD guidelines, based on the type of lesion and cancer and thorough coordination with ART staff, and who can do gynecologist, oncologist, and staff nurse, and when at the diagnosis, then at follow-up post-treatment completion as per NPA-NCD guideline. So at ART center, ensure timely treatment and follow-up visits and counseling of to ensure adherence to ART with support of care and support centers, health promoters, and thorough coordination with treating surgeon at the treatment facility, and diagnosis and throughout treatment as post-treatment completion follow-up visits. So, treatment of next slide, please. The treatment for CIN or invasive cervical cancer in women living with HIV is the same as per general population. So, if women living with HIV receiving radiotherapy or surgical intervention, they shall continue their taking their ART, and in women living with HIV receiving chemotherapy, the treating physician and oncologist shall discuss and prepare individualized plan considering potential interactions and toxicity profile of the drugs which being prescribed. Treatment including radical hysterectomy and lymphadenectomy plays an important role in the management of early stage cervical cancer, and if there is local advanced cervical cancer, the patient go for ART or radiotherapy and chemotherapy. Next slide, please. For prevention of cervical cancer, most important thing is awareness about their disease, about their symptoms, so they can reach timely at community level or higher center. So awareness generation and information giving and health promotion. How? Through campaigns, support group or community champions. And CCSC staff, peers, patient influences, champions, ASHA and ANM under NP, NCD, and at regular interval throughout the year. At ART Center, information giving and counseling on risk reduction and health promotion, and use of IEC and counseling tools and job aids, and counselor and staff nurse do this work, and as each visit to the ARC center, we should follow them. So, as nowadays we know HPV vaccine is available, but we have to buy. This is still in only 2 states they are giving HPV vaccination for female. So, early diagnosis through symptom screening, and for prevention, adherence to the ART for viral load suppression, tobacco use cessation, because they are generate toxic components, lifestyle and dietary modification, and sexual exposure prevention strategies, including using barrier protection and reducing the number of sex partners, and linkage to the NCT facility for routine cervical cancer screening. And those patients should be aware about their symptoms and what are the role of why they are going for screening through promotion through HIEC. Vaccination is recommended. HPV vaccination is recommended for routine at age 11 or 12 year, and as administered 3 doses of 9-valent HPV vaccine Gardasil 9 at 1 or 2 and at 6 months. And 2-dose series is not recommended in people with HIV positive. And for all people with HIV age 13 to 26 year who were not vaccinated previously, administered 3 doses of vaccine at 1 or 2 and 6 months. And 2-dose series is not recommended in these women. And people who with HIV age 27 to 45 year and who were not adequately vaccinated previously, the role of vaccine is not routinely recommended. Instead, shared clinical decision making regarding HPV vaccination is recommended for people who may be at risk for a new HPV infection. Next slide, please. So the government of India has adopted this WHO definition of palliative care, which is not, the active total care of patients whose disease is not responsive to curative treatment. And in these patients who become terminally ill with cervical cancer, not responding to treatment, one of the most important services which can be offered by palliative care. Palliative care should include support to their families, caregivers, and may have to extend to be bereavement support if the patient does not survive. And the support can be extended by the care and support staff visiting the house of the patient, and support from ASHA and ANM of the area, and the NCT staff nurse and counselor trained in palliative care under NP-NCT. Main component of palliative care are pain management, symptomatic management, nutritional, psychological support, spiritual support, end of life care, and counseling. Next slide. So counselor, what is the role of counselor, staff nurse, and medical officer and data manager? Counselor will give information on the risk of cervical cancer and the benefits of early diagnosis through screening to all women living with HIV. Staff nurse will document the process of referrals to nearby centers undertaking cervical cancer screening and follow-up, and keep a track of these women screen positive, and coordinate with care and support center for accompanied referral for treatment of precancerous lesion or cervical cancer till treatment completion. ARTC medical officer will refer women living with HIV ever sexually active for cervical cancer screening as per national guidelines, and update section 12 and 13 of the white card. To update the MP data manager on MPR, MLL, SOCH regarding screening as well as screening outcomes, and generate dual lists. Next slide, please. Now, Documentation Act ART Center. Previous history of cervical cancer to be documented in the medical history section of the white card. The date of referral for cervical cancer screening will be documented at column 3 of section 13 of the white card and in the green book, and updated in SOCH on a daily basis. In section 12 of the white card, that is investigation section, and the green book of the patient, the following information will be documented: the screen test used for primary screening for cervical cancer and the outcome of that screening, the information on the women living with HIV screened positive on primary screening for cervical cancer, and the date of referral for triage test is to be updated in the white card column 13 and section 13 and in the green book and ARTC referral register. OBG and NCD clinics to maintain their health registers to and from ART center. Next slide, please. So what is the role of primary healthcare, CSC, and secondary healthcare facility? And who will do? AIM, ANM, staff nurse, medical officer, or gynecologist will undertake VIA as the primary screening test, will document the finding on the green book or referral slip, and will document the finding on the national NCD portal. And at tertiary care facility or medical college or gynecology department, medical officer, gynecology, just trained staff nurse should be there, will undertake pap smear as the primary screening test and will document the findings on the referral slip oblique green book of women living with HIV. And further evaluation and clinical management, they can go for triage test. If VIA PAP screening test is positive, then we can go for colposcopy at secondary and tertiary care facility based on the convenience of the patient and availability of diagnostic and treatment services. Treatment of precancerous lesion or invasive cervical cancer is the same as for general population in the NP-NCT guideline. It has to be done as per existing mechanisms at the tertiary care facilities, State Cancer Institute, or medical college oncology department, and follow-up of women treated for cervical cancer as per the advice of treating oncologist or medical officer or in charge of tertiary care center facility and NP-NCT guidelines. Next slide, please. So key points are cervical cancer is the fourth most common cancer in women, and approximately 1 in 20 cervical cancer is attributable to the HIV. And women with HIV are 6-fold more likely to be diagnosed with cervical cancer. And cervical cancer cases 99% linked to the infection with HPV virus infection. And so cervical cancer screening should be recommended for women with HIV, and integrate cervical cancer control programs and HIV care to help women to participate in the screening, and educate them and healthcare worker about the link between HIV and cervical cancer. Though an HPV vaccine is a strategic way to prevent cervical cancer is still unavailable, so they have to buy HPV vaccine. And ART center should establish a linkage with NCD facilities for screening and management of all women living with HIV of severe cervix, and possible provision of palliative care for women living terminally ill patients. So thank you for bearing with me for this slide. I think you might so these are the common things which we are doing day-to-day care, but awareness is mandatory for this patient, so they can reach to the center. Any center is available. So thank you.
Thank you so much, ma'am, for facilitating this session. Any questions, please feel free to put your questions in the chat box. Now, mic access has been given to all. You can also unmute and ask questions now. Yeah, ma'am, we have a question in the chat box. Is it necessary for males to take HPV vaccine who are of MSM tendency?
For male, still in India, that HPV role of HPV vaccine on male is going on. the HPV is responsible oral, anorectal infections in male. They are associated with HPV. So in India, this is all still on trial board for male.
Next question, ma'am. Can you tell us
Shweta,
about yeah, ma'am.
Shweta, just a minute. I would like to add to Rajesh ma'am's comment that, as ma'am said, it is in trial mode. Also, under national program for NCD, currently it is not recommended. And probably, if there's someone, Swasti sir or someone from the team would like to add something here. Currently, it is not recommended under the program. Thank you.
Thank you, ma'am. Dr. Swasticharan, sir. Ma'am, there's another question. Can you please tell us about the screening age of women living with HIV? Screening age.
Screening, if women with living with
Yeah.
HIV having any symptoms in young age, they can go for screening test. That is either VIA or pap smear or HPV. We are taking HPV sample also. So if they are immunosuppressive or they are more chances of get positive. So we have to do this test for as soon as they are diagnosed with their HIV status.
Any more questions? Participants can please unmute and ask questions.
Shweta, just
Yes, ma'am.
adding to what just ma'am said, that in the presentation you all must have seen that ever sexually active individual up to the age of 65 years, we are screening, as ma'am rightly said, that any newly diagnosed HIV positive women and then going on who are also on ART, we have to regularly screen them. So there was a very beautiful slide in madam's presentation which was clearly mentioning that who to screen, when to screen, how to screen. That criteria is already given. So we'll be sharing the presentation for your future reference. Thank you. Over to
Thank
you,
you, ma'am. A few participants have shared their experiences about HPV screening in the chat box. Any questions? Please feel free to unmute and ask questions. We'll be soon circulating the PPT and recorded link to all the ART centers.
So, Shweta, there is
Yeah.
one question in the chat box I would like to address, that do we need to screen the women living with HIV at the ART center or at the NCD clinic? So currently what we are recommending is that we identify who are to be screened for cervical cancer and develop a strong referral linkage mechanism to the NCD clinic, or in case where ART center is there in the medical college level, then to the gynec department. So this is how we are referring. We are identifying, counseling them at the ART center, and then referring based on where the ART center is located or as per the convenience of the women living with HIV. So we are not screening currently at the ART center level. However, if there are, it is feasible based on state-specific scenarios, then if it is feasible at the RT center, then state officers are also here in this NDLS, so probably they can explore that possibility. But here currently we are, recommending that we counsel them well, and then we refer them to the clinic, to the NCD clinic or gynec department in the medical college level, and also follow them up. That's all. Thank you.
Thank you, ma'am. Any more questions? In children living with HIV through vertical transmission, and if they are asymptomatic, what's the optimal age for screening and by what method? Dr. Rajesh Kumari, ma'am.
For
Yeah. In case of children living with HIV who have acquired the transmission, the infection through vertical transmission, if they are asymptomatic, what is the optimal age for screening and by which method?
they are not active, and if delivery is done and they are active, so we should go for a viral load of mother. And as per protocol, when this child is delivered, at that time we are giving them to prophylactic treatment.
Dr. Purnima ma'am, would you like to add on?
So as I said that for screening, ever sexually active, we consider for a newborn who is diagnosed, we don't recommend to screen them. NCD team, would you like to add something here?
Kiran sir, can you please check if Dr. Nivedita ma'am is has logged in from NCD department and make her co-host?
Thank you, ma'am, for the question. Yes, ma'am. I agree with the previous speaker that only sexually active people need to be tested on a priority, screened on a priority.
Thank you, ma'am. Any more questions? We'll wait for another 2 minutes. Kiran sir, we can run the feedback poll till then.
So Shweta,
Yeah,
here
ma'am.
may I just summarize what Rajesh ma'am just mentioned in the session, and then we can run the poll.
Yes, ma'am.
So thank you, Rajesh ma'am, for such a nice presentation on cervical cancer among women living with HIV. So here, because it is, we are pilot, as Chinma ma'am said in the morning, and Swasti sir also mentioned that women living with HIV are vulnerable and they are at a higher risk of developing cervical cancer as compared to the general population. So we are also doing a feasibility assessment in 11 states, but many states are also doing this screening and then linking them with treatment under NP-NCD for women living with HIV. So here there are two important things which we need to focus, and these slides will eventually be shared with all the ERT centers and SACS officers, that we need to focus on counseling, one, referral and linkages, and follow-up. We also have section 12 and section 13 in the white card, where you can document the referral and linkages. And also in SOCH, there is a section which talks about cervical cancer, BIA, and pap smear. So after these patients report back at the ERT center, you can document it here. And as in the morning, in the starting, Swasti sir was mentioning that we are going to learn from what is being implemented from you all. So these learnings will help us in strengthening these referral and linkages in all the states. So this is what I wanted to just suggest to all the states, that once you start implementing, do share your learnings also. And this is how we can document it and also understand that what is working and what is not. So thank you, Shweta. Over to
Thank
you.
you so much, ma'am, for the closing remarks and for your guidance. There's one question in the chat box. Is some dietary chart for this symptom? Is there some dietary chart for this symptom?
Not sure. The question is not clear though. Dietary
Uh,
chart in what terms?
Ranjan Singh, sir, can you please unmute and ask your question? So you can please write to dlcsinfo@itecindia.org. Yeah. Any more questions? Kiran, sir, you can start the feedback poll. Yeah. The NDLS feedback poll is now on the screens. Participants are requested to please attempt the feedback poll. You'll have to click on the answer of your choice. Thank you so much, Dr. Swasticharan sir, for joining us today and for the opening remarks and guidance. Thank you, Dr. Chinmoyee ma'am. Thank you, Dr. Rajesh Kumari ma'am. Thank you, Dr. Purnima ma'am and Dr. Nivedita ma'am, for your guidance. We'll soon be sharing the NDLS PPT and recorded link with all the ART centers and SACs. Requesting all the participants to please attempt the feedback poll. Also visible on your screen is the QR code for downloading the National Guidelines for HIV Care and Treatment 2021. This is a technical guidelines. It is now available in the mobile app format. Please feel free to scan the QR code and download the guidelines. This has been updated. The guideline can now be downloaded in a PDF format. There are notification alerts that can be activated. There are other resources like the ART adherence calculator, serum creating calculator, and even a link has been given for the NDLS recordings. You can share the PDF pages with people, and you can. There's also addendum about the year-wise OMs that have been released from NACO.
Ma'am, may I question
Ji.
ask one more question?
Yes, sir. Please.
Ma'am, I'm Dr. B.N. Tripathi from Bhubaneswar ART Center, Odisha. So my question is, why multiparous women are more likely to have HPV-related cervical cancer?
Dr. Rajesh Kumari, ma'am. So can you please repeat the question?
My question is, why multiparous women are more likely to acquire HPV-related cervical cancer?
So that is depend on their sexually active and when they are sexually active, because HPV infection is mainly transmitted disease. So whenever their marriage age, their parity, we are looking for these.
Madam, is there anything to do with the male partner?
Yes, sir, we have to counsel them. There is that on that condition, male and female both partner should counseling regarding status of disease, regarding further management for HIV, also for screening of this cervical cancer, because this is sexually transmitted.
Okay, thank you.
Thank you, sir.
Thank you, ma'am. Thank you to all the participants for patient listening, and thank you for attempting the feedback poll. We'll conclude the session now.
Thank you, Rajesh ma'am.
Thank
Swastika.
you. Thank you, sir.
Sweta.
Thank you, ma'am. Thank you, Shweta. Thank you, Dr.
Thank you, ma'am.
Purnima. Thank
Thank
you.
you. Thank you.